you have hemorrhoids, you have a number of irritating problems. They're not going to kill you, but they're going to continue to be a problem, and they'll run highs and lows. But when you've had enough of your hemorrhoids that you want to do something about it, you need to know what you're getting into and why. Hemorrhoids are a varicose vein of the anal canal. The vein gets bigger. Sometimes it's inside and hidden entirely, but the poop coming through brushes it and it starts bleeding and drips and gives you a lot of bleeding around bowel movement times, but is generally not too painful, not too irritating. Hemorrhoids on the outside are a varicose vein that is expanded on skin that is very sensitive. And that can lead to itching, that can lead to pain, that can lead to irritation when you're sitting on it. And sometimes that vein will get big enough that the blood flow stops and it gets blood clots in there and causes significant and severe pain. So internal hemorrhoids cause bleeding painlessly. External hemorrhoids cause irritation on the outside, sometimes severe pain, but the more it's a pain issue, the more you're dealing with an external hemorrhoid, the more it's bleeding, generally the more it's an internal hemorrhoid, and frequently people have both. The anal canal is narrow. It opens up when you have a bowel movement and shuts back down again, but it's only got so much space for things to come through there. The pressure by which it comes through makes a difference in terms of the hemorrhoids because they're volume dependent and pressure dependent because it's a liquid-filled substance, the veins. So if you have a lot of intra-abdominal pressure trying to push a hard stool through, you're going to blow up those veins and make them more irritated and generally end up with bigger and bigger hemorrhoids. So part of the treatment and prevention from hemorrhoids is your diet. Try and make a habit of looking at your bowel movements. If they're little stringy bowel movements that are sitting in the very bottom of your toilet, it's probably because you have not had much fiber in your diet. Fiber tends to float. It traps gas, it gets the bowel movements to the surface, and it results in a larger turd. If your bowel movements are this big around and they push out like toothpaste, you've probably had a lot of fiber in your diet, and you're probably not generating a lot of pressure to have a bowel movement, and you're going to aggravate your hemorrhoids less. So the fiber in your diet can come from fiber medications like Metamucil or Citracel, FiberCon, Consul. Those additives can really make a difference in terms of how much irritation you're getting from your hemorrhoids. And many times can make you think, I don't need a surgery for this. And you'd probably be right if that's a lifelong habit and they're not that big. Another way to get fiber is to do it the way most of the world does, and that is they don't eat processed foods. Lots of fruits and vegetables. The grains brown instead of white. Brown rice instead of white rice. And get as much fiber in your diet in the process of eating a good, healthy, balanced diet so that your bowel movements are this big and floating and you generate less pressure getting your poop out. If you've got irritable bowel and you're between hard stool and runny poop that's blasting out of there, you're going to have problems with your hemorrhoids no matter what you do because of the unpredictability. So getting the irritable bowel under control by probiotics or fiber or other medications are going to be your best method to keep the hemorrhoids from becoming a big issue as you get along. But surgery is generally done in patients where there's a lot of extra tissue down there that's falling out and in the way and causing more and more trouble. Frequently, those patients will find that they're wiping 5 times, having to use witch hazel or some sort of medicated wipes because they can't get things cleaned out in the crevices and there's too much hanging out or they have to push things back in. And if you've got extra tissue, lesser measures are not going to work, and surgery is going to be necessary to get out of those kind of problems. There are a couple of things. If it's an internal hemorrhoid that's falling out and bleeding, many times that can be done in the office as a banding procedure with no anesthetic because they're generally painless, and put a little tiny rubber band around the extra tissue and let it strangle it. It falls off and get a little gush of blood, and that's the end of it. Hemorrhoid banding is generally done by the gastroenterologist. Sometimes the family docs will do it. Sometimes the surgeons will. But it's an office procedure. Many times it needs to be done 2 or 3 times. But it usually is in the setting of painless red bleeding with bowel movements with associated small internal hemorrhoids. If you've got external hemorrhoids, the banding problem will only cause severe pain that will not go away. So you're better off with a hemorrhoidectomy if that's necessary. So hemorrhoidectomy operations are usually done either under heavy sedation or a general anesthetic. Most people are healthy enough, they don't need to be done in the hospital setting, so an outpatient setting like Meridian Surgery Center can meet that need very well. Typically people are in the surgery center 3 to 4 hours, an hour getting an IV started and meeting the anesthesia provider, an hour or less in the operating room and an hour or more in recovery room, waking up and getting ready to go again. The hemorrhoid surgery process involves cutting out the redundant tissue there, placing sutures, and stopping all bleeding. After the hemorrhoid area has been sewn up, we'll be putting some packing in the anal canal that allows for delivery of local anesthetic directly to the suture area, and also some pressure to prevent bleeding. That packing will stay in there from 4 to 24 hours, depending on how you tolerate it being there. It'll come out just like a bowel movement if you sit on the toilet and strain a little. It's loaded with lots of numbing medicine that's lubrication also, but it's cotton, and if you flush it, it will plug up your toilet, so don't do that. The big problem with hemorrhoid surgery is pain. The first week after the operation, it will feel like your rear end hurts a lot. And I would say make no social obligation plans at all for 1 week after hemorrhoid surgery, and you'll take a lot of stress off yourself. The first issue is that it's painful. 2 types of pain back there. The first is kind of the stitches going in there. It feels like there's a rat biting and things are tight. The second pain is a muscle spasm, kind of like a Charlie horse. That round muscle of the rear end, if it goes into a spasm, will feel like a Charlie horse, and the narcotic pain medicine won't break that pain. So we give you a couple of different pain medication options in the process of getting over the hemorrhoid surgery to minimize the pain that you're going to experience with that operation. So the first is a topical lidocaine ointment. That's partly what's in the packing on the inside, but we give you a tube of that at the pharmacy to apply. Some people think it's really helpful, other people not. Anything to decrease narcotic use is useful, so we give it a try. The second is a muscle relaxant to minimize the spasm issues back there. It's Flexeril. People use it frequently for back muscle spasms. You take it a couple of times a day. You might not have muscle spasms initially, but once you start having bowel movements, you may find that that's the case. And that will not respond well to narcotics and be constipating. So the muscle relaxant is a good way to deal with the primary issue there and smooth that transition for the first 4 or 5 days. But the pain is usually bad enough that people are needing narcotic pain medication. And so we're going to give you some. We don't like to refill those, minimize potential for abuse and getting dependent on them. And the pain is usually the worst of the first 2 days. But the number one side effect from narcotics is constipation. And if you get constipated and have a hard stool that needs to come through a recent operation, nobody likes the idea of that, much less the experience of that. But I can tell you that that hurts less than you anticipate, but you still want to keep an eye on your bowels and not get constipated. I had a lady once that really volitionally did not have a bowel movement for a full week after her hemorrhoid surgery, and she ended up with a manual disimpaction in the hospital because she couldn't push it out no matter how hard she tried. Keep your bowels working. Use fiber as that mechanism. So drink plenty of fluids, be eating fruits and vegetables, get extra fiber in your diet. If you're a constipated person at all, take a laxative. You would rather have the runs in 2 days than bricks in 4 with a hemorrhoid surgery, for sure. Number one distress call that I get, and it's hard to give you an enema after a hemorrhoid surgery, and nobody wants to. So be proactive, keep an eye on your bowels. If you're always got diarrhea, you may be constipated for the first time. If you're always constipated, you definitely need to be taking a laxative. Stool softeners are helpful too, but be liberal with the use of laxatives in the recovery from hemorrhoid surgery. So then, once you get through that first week, the pain will drop off considerably because at the end of that first week, the stitches that are there begin to dissolve and fall apart. We put in dissolvable sutures because you don't want me to be taking stitches out of your rear end a week or 2 after surgery. But the dissolving stitches take pressure off. By then, the bleeding will have been a way smaller problem. And the pain will drop off considerably. And as you have a bowel movement, the anal canal will open, those weakened stitches will break loose, and you may get a gush of bleeding, generally around a week after surgery, after which you're going to feel a lot less pressure back there. But remember, that's a vein that's been cut out and sewn back around, and sometimes that bleeding can be a big deal. If you're on blood thinners or aspirin, you may find that bleeding is a lot of bleeding. And most people with hemorrhoids are used to seeing some blood, but if you've got blood that's not stopping, I need to know about it soon. I've seen 2 patients in 25 years with exsanguinating bleeding after hemorrhoid surgery, massive bleeding that needed a reoperation right away. And neither one of them were my patients. They were patients that came to the emergency room. Some other surgeon had done this hemorrhoidectomy. And there was a phase when we were going through hemorrhoid surgery just by burning them off. And these are techniques that we now are not doing so much anymore. But at that time, if you burned off the hemorrhoid, it would be okay. But when that clot sloughed off a week later, they ended up with severe bleeding problems. But that is rarely seen unless now you're on blood thinners already. So if you can avoid blood thinners until that first week is over with, that's a preferable situation. Hemorrhoids can recur. Lifelong, you want to have high fiber in your diet. Again, you want bowel movements that are this big. The more you're having little ones down here that are in the bottom of the toilet, probably you're straining and increasing the hemorrhoids. And it's not uncommon that patients will end up with hemorrhoid surgery 10 years after their initial hemorrhoid surgery because they haven't paid attention to those details in their lifestyle. After your hemorrhoid surgery, you'll go through that bleeding episode, the stitches will open up, and that now means that in your anal canal, you've got an open wound. And if somebody took the stitches out early on any other place in your body and it opened up and you smeared poop on it once or twice a day, you'd have a very high infection rate elsewhere. But the good Lord designed the rear end to be generally resistant to that kind of thing. But you will have an open wound in your rear end that will be there for about a month after the hemorrhoid surgery. And that you need to keep clean, you need to keep dry. And you need to have good control of your bowel function. So lots of fiber, clean well after your bowel movement, shower and use a washcloth to clean the crack back there when you shower. And with your last wipe with bowel movements, use a diaper wipe or a Tux so that you have a medicated structure back there that's just keeping the germ count down. But clean and dry usually does the trick. There are circumstances where infections can occur in the anal canal after hemorrhoid surgery. It's usually 2 to 4 weeks after surgery, frequently in diabetics if it occurs. and it will be manifest with severe anal pain with a fever over 101. If you got a high fever and new anal pain that's happening 2 to 4 weeks after hemorrhoid surgery, you've got an infection. I need to know about it right away. We need to get you on antibiotics for that real quick. Antibiotics usually solve it, but we need to take a look at it. I had one patient that tried to tough it out, and she ended up with a big operation to deal with it. So don't be that person. But clean and dry usually will do it for you, but that's what to watch out for a month later. Once your hemorrhoid operation is behind you, then you'll be able to increase in your activities. You'll find that jogging and walking briskly with your buttocks going like this right after a hernia or hemorrhoid operation really is not going to be comfortable. And certainly for a couple of months afterwards, riding a bicycle, a motorcycle, a horse, any of that direct pounding trauma to the rear end will not be tolerated well. You'll get back to all those activities with time, but give yourself some leeway and let yourself get over the operation before you do bigger stuff. Generally, the decision to have a hemorrhoid surgery is a decision to deal now differently with the nuisance problems that you've got going on for a long time. When you've had enough of it and you can find a window in your life where this kind of a recovery can work, we can help you out at Meridian Surgery Center and make that as smooth a process as possible. Okay, now I've got a really unpopular subject, and that is complications after surgery. All surgeries have potential complications. Some surgeries have different complications from others, but there are some that need to be watched out with every operation. One of those are things that people naturally are afraid of, and that's bleeding. For most operations, the risk of bleeding is relatively low, amounts to bruising, and rarely results in transfusion. If you have religious objections to blood products, be sure and let your surgeon know about that. But rarely do we need to proceed on with any bleeding, transfusion sort of issues in general surgery and the stuff that I'm generally doing. But there are a few things that can increase your risk of bleeding that you need to be aware of. Aspirin increases bleeding, it increases bruising substantially, and unless your doctor feels like you need to be on aspirin despite the fact that you're having surgery, most patients will be taken off of aspirin. Likewise, ibuprofen, Aleve, any of the non-steroidal anti-inflammatories also have the same effect on clotting. So we'll generally have people off of those medications for a few days before surgery. External bleeding is very obvious. If you've got a spot of blood this big on your dressing, it's probably going to stop on its own. If your dressing, however, is soaked and looks like it's continuing, you need to notify your surgeon right away. Frequently, that will get better just by applying pressure. But if it doesn't, it will need to be addressed during a close time frame there. Don't be polite to your surgeon. I like that if you are, but don't wait till morning if you've been bleeding all night. That can be a real problem. And let the surgeon know if you're soaking your dressings. The other way that you know you have bleeding is something you might not think of up front. For most operations, we want you up and around the house the night of surgery. And walking is good. It prevents blood clots. It keeps you mobile. But it also gives us an early warning sign. If you're attempting to walk the night of surgery and you're pale and you're passing out, that's either a heart problem or that's internal bleeding. That's an automatic trip to the emergency room, and nobody should talk you into going to bed because you're dehydrated, you just need to rest. If you're pale and passing out, or just passing out period, when you try and walk, that's internal bleeding and needs to be evaluated that night. Call 911, call me on the way. Infections are also a risk with surgery, and anytime the intestines are cut across, there's a higher risk of infection. Wound infections are not common at Meridian Surgery Center. The risk is about 1%. If your wound is red and angry, if it's draining pussy stuff, if you're having a fever over 101, those infection symptoms are generally going to occur in the first week to 3 weeks after surgery. It's a nuisance. It might scare you, but it's probably not an emergency that requires an emergency room visit. And if you go to the emergency room, you're going to be there 10 hours. Calling the surgeon, texting a picture is the better way to do it, way faster, way cheaper, and will save you a lot of trouble. I had a patient 2 years ago who was pacing in the emergency room with this problem. He'd been there 4.5 hours, was getting really mad. Other people were going ahead of him. He wasn't getting any attention. And he just went, I'm supposed to be calling Dr. Wright. What am I doing here? And we had it all figured out for him within 15 minutes. So be aware, the emergency room isn't generally the place for that kind of a problem. Let's get it taken care of. Anesthesia-wise, your operation generally involves anesthesia. Local anesthetic has very minimal risks, but if you're allergic to lidocaine or bupivacaine in the dental office, we need to know that because that's what we're generally using, something related to that. General anesthetic and sedation procedures have risk of anesthesia as well. We're generally evaluating that in the clinic as we go along with the surgery evaluation. And patients with high risk are generally done in the hospital setting. Patients with intermediate risks and low risks are in this outpatient setting. But that's part of why we're doing blood tests and EKGs in evaluation before surgery. And sometimes you'll be set up for an outpatient surgery, and those tests will either cancel the surgery and require a cardiac evaluation, or change the setting of the surgery, or tell us something else needs to be done before the operation is done. But we deal with, in the outpatient setting, minimizing the anesthetic risk and getting you through the operation as smooth as possible. You'll be speaking with the anesthesia provider specifically about your situation the day of surgery before you go in for surgery. If you have sleep apnea at baseline, we do ask you to bring in your CPAP mask because that can be helpful in the recovery phase when you're not breathing so well and when you're not as awake, sort of like it helps you at night. Medications that we give after surgery can have reactions too, particularly if you've never seen them before. If you've had problems with certain pain pills before, we need to know that up front so that we don't get you into the same trouble that you had before. But generally, narcotic pain medications are constipating. And the number one distress call I get is usually 4 days after surgery. Somebody hasn't thought about how their bowels are working. They've had their surgery, they're doing okay, but now they can't poop. And it can be the most miserable part of your operation if you're bloated after an abdominal surgery and you can't poop and you have to push it out, and nobody wants to give you an enema. So you need to be proactive on that. So the night of surgery, drink plenty of liquids. When you're starting to eat, don't jump into meat and potatoes. Instead, fruit and vegetables. You want lots of fiber in your diet that will help you with your bowels in that immediate postoperative period. And if you're a constipated person in the first place, clean out before surgery, take laxatives, and keep your bowels working. You would rather have the trots in 2 days than bricks in 4. But certainly keep an eye on it. If you normally have really good bowels, you don't even have to think about it, be thinking about it. If you haven't had a bowel movement in 2 days, you need to take a laxative and get things going and make sure that you don't get bound up. That's the best way to have a smooth operation after the operation. So when it comes to complications, nobody can tell you all the possible complications. There are a number of things that can go wrong. Your informed consent forms will give you a lot of answers there. But generally speaking, the more experienced your surgeon is, the less complications you're going to have because they've seen things before, and that experience helps them keep their patients safe. So at Meridian Surgery Center, you'll see a lot of experienced surgeons and providers at your bedside, guiding you through your operation to minimize your potential for infection.